My name is Benjamin Lebwohl, and I am a gastroenterologist and clinical investigator at Columbia University Medical Center and New York Presbyterian Hospital. Today, I will be discussing our paper titled The Impact of Suboptimal Preparation on Adenoma Miss Rates and the Factors Associated with Early Repeat Colonoscopy. The genesis of this study occurred during my fellowship training when I was performing a colonoscopy in which the preparation was poor. My preceptor asked me, "What is being missed during a suboptimal preparation?" It stands to reason that in a suboptimally prepared colon, polyps, especially small ones, may be missed. But we know this to be the case even in optimally prepared colons, based on multiple studies involving tandem colonoscopy. In those studies, patients underwent immediate back-to-back procedures, and about 25% of all adenomas were only found during the second colonoscopy. Fortunately, most missed lesions were small. The adenoma miss rate for larger lesions, such as those greater than 10 millimeters in diameter, was closer to 5%. So if 25% of all adenomas are missed when a preparation is optimal, what is the miss rate when a preparation is suboptimal? That is a clinically relevant question. In multiple observational studies of colonoscopy in clinical practice, approximately 20% of all colonoscopies involve a suboptimal preparation. Now, the definition of a suboptimal preparation varies in these studies, and there is likely a large amount of subjectivity. Nevertheless, we are left with the widespread phenomenon of gastroenterologists having doubts about the quality of the bowel preparation in 20% of all examinations. In these circumstances, the gastroenterologist faces a question that guidelines and the existing medical literature do not answer. When should the examination be repeated? What is being missed? In the present study, we performed a retrospective analysis of all colonoscopies performed at our medical center's endoscopy suite. We had two aims. First, to identify factors associated with early repeat colonoscopy following initial examination with a suboptimal preparation. In other words, we sought to answer the question, who has an early repeat colonoscopy? Second, we aimed to measure adenoma miss rates in this context. We identified 3,047 patients whose preparation quality was suboptimal. This amounted to 24% of all colonoscopies. Of these 3,047 patients, an early repeat examination, as defined by a repeat colonoscopy within 3 years, was performed in 505, or 17%. On multivariate analysis, factors associated with an increased odds of early repeat colonoscopy after suboptimal preparation included lack of cecal intubation, with an odds ratio of 3.62, and finding a polyp on the index examination, odds ratio 1.55. We performed a sensitivity analysis in which we redefined early repeat colonoscopy as that occurring within 1 year of the index colonoscopy, and these associations were unchanged. When we examined individual providers, there was a striking variability in the rate of early repeat examination after suboptimal preparation, with some providers repeating more than 30% of suboptimally prepared exams early, while others repeated fewer than 5%. As for adenoma miss rates, we identified 216 patients who had a full colonoscopy to the cecum with a suboptimal preparation and an early repeat examination with optimal preparation. The overall adenoma miss rate was 42%. For small lesions, i.e. 5 millimeters or less, the miss rate was 48%. And for larger lesions, or those with advanced histology, the miss rate was 27%. Now again, the overall miss rate on tandem colonoscopy studies in which the preparation is adequate has been reported as 25% and 5% for advanced lesions. Our findings of miss rates of 42% overall and 22% for advanced lesions support our hypothesis that suboptimal preparation has significant deleterious impact on the effectiveness of colonoscopy in clinical practice. How might these results impact our decision-making when we encounter a suboptimal preparation? For one, the decision to repeat the colonoscopy early might hinge on what we found to be the incremental yield of such a repeat. For example, if no adenomas were found on the index examination, only 20% of patients had an adenoma on the repeat. In contrast, if one or more adenoma was seen on the index examination, 36% of those individuals had an adenoma the second time around. So one approach to the suboptimal preparation may be to repeat the colonoscopy early if an adenoma was removed. Others might consider the overall miss rate of 42% as unacceptably high. warranting consideration to repeat all suboptimal preparations early, even if most of these missed lesions were small. We would not expect one study to provide a cookbook set of instructions on how to respond to the common problem of suboptimal preparation. Our study has a number of limitations, including its retrospective design, the lack of controls, and the fact that the majority of individuals with suboptimal preparation did not have an early repeat examination. Those who did not have an early repeat colonoscopy may differ in important ways from those who did. It's clear, however, that suboptimal preparation adversely affects the quality of colonoscopy, and future research efforts should focus on eliminating or greatly reducing the incidence of suboptimal preparation. Effective interventions, such as split dosing, have demonstrated that we can improve preparation quality and, in turn, the effectiveness of colonoscopy for the prevention of colorectal cancer.